All right, everyone, thank you so much for coming. For those of you who aren't from here, my name is Katherine Hansen. I am the medical director of our exercise lab and pediatric cardiologist. And I'm thrilled today to have our keynote for our first ever Heart Club sessions. Heart Club is our home exercise intervention program here at the University of Michigan, where we practice teaching exercise, physical activity, and resilience behaviors to individuals living with congenital heart disease. And the idea behind Heart Club sessions was to bring together a group of people who think about these types of questions that have very different kinds of backgrounds and will help generate hopefully some discussion about how we do things here at Michigan Medicine, how you do things at your center, and ways that we can kind of work together in this really exciting area. I'm very excited to introduce our keynote speaker for Heart Club sessions, Katherine Hansen. Katie is a pediatric cardiologist and an exercise cardiologist at UT Southwestern. I met her several years ago when she was an advanced fellow in cardiac exercise at Boston. And I really appreciated the things that she's taught me over the last few years. Important to note, there's no relation that everybody asks. We just happen to have a really good last name that's the same. And so this is a really exciting week at University of Michigan. We have Heart Club sessions. In the middle of the week, we have our Nyland lecture, which is a prestigious invited lectureship. And then later this week on the weekend, our awesome class of fellows is graduating. So we're kicking off a really exciting week here at the University of Michigan. And thank you very much, Katie, for accepting our invitation to speak today.
Thank you, Jesse, and thank you all for being here. I'm early in my kind of career in exercise cardiology, and Jesse's been a huge mentor for me. So even though we're not actually related, he's kind of my exercise cardiology big brother. So we're going to go with that, even though it's not a biological relationship. It's an exercise cardiology one that I've really, really appreciated. So today, I didn't really get a whole lot of borders on what I could talk about. So I'm really going to go kind of different directions and really bring a lot of kind of my story to how I came to exercise cardiology and how I bring a lot of my values to what I hope to bring to patients. So we'll go in a few different directions and take some circuitous paths, but really the whole theme is fitness for life and how exercise training can really help our patients with congenital heart disease develop fitness for life. So I'm from San Diego. It's a little town that's Coronado is a little town in San Diego that's covered by water. So I actually grew up swimming and doing all kinds of water sports throughout my life. And it's very different than where I live now, which is in Dallas, and I miss the ocean a lot. But one of the things that I really valued is I played water polo growing up, and that actually ended up being really impactful in my life. And as I'll kind of get into, really, I think is the gift that keeps on giving, at least for me, in terms of how exercise has impacted both my career path and my personal life. I ended up playing water polo at Stanford, and after a brief stint for med school back in San Diego, I went back to Stanford and did all my medical training there. So I did pediatrics residency and then pediatric cardiology fellowship there. And as I was getting towards the end of pediatric cardiology fellowship, I was, there's like maybe 5 or 6 kind of well-oiled paths that I think a lot of people do in terms of advanced training. And I was kind of looking around and I saw that exercise wasn't really one of those things that I kind of thought it should be. And so I started reaching out to a bunch of different people to see how I could make that happen as a senior fellowship. And luckily, the folks at Boston were thinking the same thing, and they were in the process of developing the first ever exercise cardiology specific fellowship. So I got to go there and be part of a really incredible group. I think I see Rachel on the call. So she's one of the exercise physiologists who taught me a ton while I was there, along with the whole team at Boston. And really set me up well for what ended up being, my job now, which is as an exercise cardiologist in Dallas at UT Southwestern Medical Center. And the job there is really to develop exercise cardiology. So it's been a really unique, opportunity to kind of think about what do we want that future to look like and what do we want to do as kind of a subspecialty. There's a group of us across the country who are really trying to grow this. And it's been really exciting to be part of that group. While my husband was moving my 2 kids and 2 dogs from Boston to Dallas, I got to go play water polo in Japan. So actually the team that I played with kind of throughout college and high school and girls I played against, we all got together to play in the old lady world championships, which was really fun. And it was just a good reminder, again, how, exercise really was this gift that kept on giving. And I think about that often as kind of the long-term relationship that I've had with exercise and sport and teams, and how it's not just about the sport, but it's about all the things that you kind of learn along the way and through exercise, and how I really hope to bring that to my patients, or at least some parts of that. So that's a little bit of my background. I mentioned exercise cardiology is this growing field, and I really think of it as sort of, at least the way I'm building it, and Dallas is kind of three aspects of this subfield. So there's the exercise testing where we do in the exercise lab, so the diagnostics piece of it. And then I think of it as having therapeutics as well. So that's where the exercise counseling, prescription, and training comes in. So we have our exercise cardiology clinic, and then similar to Heart Club, we have just started 2 months ago our cardiac fitness program, which I'll get into a little bit. So this is what I think of as exercise cardiology. Today, we're going to really go into the cardiac rehab and what does that mean when we apply it to kids with congenital heart disease. So we'll go through the cardiac rehab evidence for adults. What is cardiac rehab? How do we apply that to children with congenital heart disease? And really thinking about what the need is for kids relative to maybe what the need is in adults, and how that need might be a little bit different. And actually, Mike, this morning we were talking about what are the goals? Like, I think that's actually such an important question. I think about it all the time. What are we really trying to achieve when we do exercise training? And where we'll kind of end up is what is fitness for life, and maybe what are some of the missing pieces that exist, that when we try to take cardiac rehab for adults and transplant that to kids, where are we kind of missing some of the pieces, and where do we need to think about how it more specifically applies to children? So we'll start with adult cardiac rehab. So I like to start with this because really for decades, it's a class 1 recommendation for adults who develop certain types of acquired heart conditions. And the reason for that is because the evidence is pretty clear that it's beneficial. It reduces all-cause mortality, cardiac mortality, hospital readmission rates, improves adherence with preventive medications, and then importantly, improves quality of life and modifiable risk factors. And there's this dose-response relationship with exercise. The more you do it, the better off you are. And so this is true for across the board in acquired heart disease for adults, but also there's quite a bit of evidence for kind of sub-diagnoses within adult cardiology. So in heart transplant, these same findings exist, and frailty has been one of the important things that we're trying to look at, and in children as well, and how that relates to mortality. So for cardiac rehab in adult heart transplant recipients, 30% lower readmission risk, 60% lower major adverse cardiac event risk, and again, the number of sessions predicts survival. And so really that ultimately has led to major guidelines saying that cardiac rehab is recommended after transplant to improve exercise capacity and a bunch of different things that are really important to how you function in life. Also true in pulmonary hypertension, the 2015 pH guidelines recommend that stable pH patients should take a supervised exercise training program. And I really like this resource because it really goes through a lot of the mechanisms through which exercise is thought to help this particular population. And in adult congenital heart disease, growing evidence. So I like this this review on exercise intolerance in adult congenital heart disease. So what they say is that exercise capacity is depressed in ACHD patients, even those who are asymptomatic, which is, I think, the utility of exercise testing to really quantify some of the deficiencies that might not be, unveiled, and just asking kind of the subjective question of how limited do they feel in terms of exercise. But this impaired exercise capacity is really uncommon, even those with simple CHD, which I think points to the patients who maybe don't even have a cardiac limitation to exercise, but there's a lot of other factors that go into deconditioning and what might limit them from actually participating in physical activity and exercise. And in ACHD patients, it's been associated with mortality and hospitalization. So I think this is important. The education piece is key. So, a lot of patients, even patients with simple heart disease, who we as cardiologists might not think have a real limitation from a cardiac perspective to exercise, have fears or concerns about exercise. And I think, if they're not addressed, then that can really contribute to their daily participation in exercise. But historically, this population has not participated in cardiac rehab in the same ways that the acquired heart disease population has. So potentially pointing to a place where our pediatric kind of programs might actually have some application for these adults as they move on to, adult providers. So there's a randomized controlled trial of cardiac rehab and ACHD. Dr. Patowski did. So looking at 12-week cardiac rehab versus standard of care. And the group that they had, so low numbers, but they were more middle-aged patients, higher BMI, and actually pretty impaired exercise capacity with peak VO2 58% predicted. And they showed that in the patients who standard of care, so no cardiac rehabilitation, their exercise capacity declined over time, whereas those with cardiac rehab actually had an improvement of 3% predicted. So, not a lot of randomized controlled trials in our field, but it's nice, I think, to point out the ones that do exist and that they actually do indicate that there's a benefit. So what is cardiac rehab? It's defined as a physician-supervised program that furnishes exercise prescription, cardiac risk factor modification, psychosocial assessment, and outcomes assessment. And there's kind of core competencies that are part of that cardiac rehabilitation model that are really primarily focused on adults, the things that matter in acquired heart disease. And we'll get into why maybe not all of them really apply directly to kids. So across the world, there's guidelines and recommendations around what the training elements of cardiac rehabilitation should be. Busy slide, really the point is to show that there's a range in terms of the exercise intensity and how you quantify that when you're doing exercise training, the duration and frequency of that exercise, how you actually test and monitor for patients as they progress through an exercise training program. But this type of exercise is pretty similar. So there's the aerobic, there's the resistance training, and then maybe a little bit of flexibility tied in there sometimes. And so we have recommendations from the US, Europe, Canada, that all are very similar. World Health Organization also similar in terms of the types of exercise and training elements that are incorporated into training. So now we'll think about how does this model apply to kids with congenital heart disease, and where does this give us, as people who are trying to think about how to develop exercise training programs, an opportunity to really innovate and identify the gaps. So first, we'll kind of start with our field. I mean, I think pretty much every paper that talks about, the interventions in exercise training on kids talks about how our field has changed so much over the last 50 to 70 years. And it really has. We've done this phenomenal job of intervening on children with critical illness that otherwise would have died early on to enable them to survive to adulthood. And now that they are surviving to adulthood, we're seeing a lot of morbidity related to being a survivor of serious heart disease. So I like this paper, this Rehan et al. Looks at the medical and psychosocial disease burden in adults with congenital heart disease who at age 50. And really the results are pretty sobering. So a lot of patients had pretty complex disease that they were looking at. TET and cohort patients found that at least half of them needed an open heart reoperation at some point. At least for TETs, 40% had a pacemaker or ICD in place. And less than 2/3 were employed, which I think really points to some really interesting other things that are going on. And then more complex CHD, they have high incidences of psychosocial morbidity, including half being diagnosed with depression or anxiety. So I think while they're surviving to adulthood, when we actually look at them in adulthood, not a lot of them are actually thriving. And as a field, I think the benchmarks for successfully caring for our patients really needs to shift from this enabling survival to thinking about what it looks like to thrive, and how do we as pediatric cardiologists set them up for that success later in life by helping to teach them the skills that they might need to thrive as adults later on. And I personally really, obviously a little biased from an exercise perspective, but I see exercise as a really amazing way to teach these skills. So that's the kind of perspective that I've taken on it. So when we think about what the need is, I think about kids who are having their surgery and what that looks like for both them and their parents, which, I think this is a pretty traumatic event for a lot of patients and for their whole family unit, and how that shapes their perspective as they move, from being an infant or even fetal life into getting their surgeries into preschool age. As they move through life, that is, I think, really impacts how they look at their child's participation in the world and activities. And I think it's understandable. A lot of parents worry about stressing a stressed heart, right? And what does that look like? And whether implicitly or explicitly there's been restriction. I think there's a lot of the psychology behind that, I think, is really important. So when I think about what the need is, I think it's really about fitness, and we talk about kind of rehabilitation versus fitness, and we'll get into that in a second. But I love fitness because I think it's such a more holistic term that applies a lot more to this child. Like what we want for this child is for them to develop fitness for life. And that's I've looked all over, and there's a lot of definitions for fitness, including what your peak VO2 is and what your survival advantage is. There's a lot of different ways to think about fitness, but I like this definition that it's the ability of a person to live a happy, well-balanced life that embraces the physical, intellectual, social, and spiritual aspects of a person's life. And really importantly, like we talked about today, it's a relative term. So it's not an absolute level of fitness that applies to all people. It's really individualized, and you really have to think about what the individual needs to be fit for life. I like this picture. This is Shaun White, who is a 4-time Olympian and someone who has astrology fellow. And I love this because, it's not like we're trying to say every kid can be an Olympian, right? But we're trying to teach them that they can actually set goals. They can struggle, and that's okay. And that struggle is part of the process of learning life skills. So yes, that experience of undergoing heart surgery and being someone who has congenital heart disease is actually a really important part of what helps you grow your superpowers, is how we like to say. Like it's a means to grow, a means through which you had to struggle and overcome adversity. And I think actually that's a really important part of being a kid and learning how to become fit for life as an adult. So that's where this kind of rehabilitation versus fitness comes up. Obviously, we talk about cardiac rehab because it's what kind of medicine in general uses as the term. But especially with kids with congenital heart disease who maybe have never had, prior state of health that you're trying to rehabilitate back to, I much prefer fitness as the definition that really helps us think about what are we really striving for our kids, and what's the goal? And again, this is really about meeting patients where they are. So in terms of pediatric patients with congenital heart disease and exercise, I think there's some mixed data on this, but I think overall reasonable to say that a lot of them participate in less physical activity than their healthy peers. And there's a high prevalence of obesity, maybe not necessarily more than their peers, but a high prevalence of a quarter of patients with congenital heart disease being overweight or obese. And I think it's also fair to say that those with severe congenital heart disease or dysfunction do have significant obstacles to normal activities of life in terms of their participation in school and other activities that are part of their daily life, and that can affect their quality of life. What I think is really interesting, and something that we also often assume, is that patients with simple heart disease don't have those limitations. And I don't think that's true, because I don't think that we fully appreciate the ways that the psychology of being a patient who might have undergone surgery actually impacts how they think about their life. So I think that's something that maybe we need to dig a little deeper and understand. And then I think as part of this kind of digging a little deeper and how we think about counseling, only 1 in 5 children with CHD receive medical advice on physical activity. I think that depends on the institution and the provider and lots of different things. But I think that's definitely something that, we should start shifting the needle to think a little bit more proactively about how to do that. And so, historically, there's been this kind of restriction that we think about, and how that's really changing, right? Over the last 10, 20 years, people are thinking about broad restriction as not really being appropriate for children with heart disease. But there still remains this fear of unknown, this possibility of a sudden cardiac event, and lack of evidence to really support proactive prescription and proactive promotion. So I think overall, as a field, we've been focusing on these small possible risks that are really difficult to quantify. But like Jesse said this morning, we're missing what we really know, which is that if you're sedentary, that actually carries a really well-known risks down the line. So when I think about our role as medical providers, Jesse senior authored this paper that I like this figure because I think it kind of gives a framework to think about where exercise testing or exercise assessment fits in. So kind of the green bottom of the pyramid is where we actually do our physical activity assessment. And then that can inform where they might go into the pyramid in terms of what kind of exercise therapeutic we might offer, whether that's promotion or prescription or a medically supervised program. So that comes to kind of where our role as providers can come in as in terms of the exercise promotion piece. I think this is a cycle of sedentariness that I think we often see that really starts at a really young age with diagnosis of congenital heart disease. And even if a provider doesn't necessarily restrict, they might not actively promote. And I think that that can really lead to fear and question marks from the family about what their child can do. And the default being to restrict if you don't actually know that you need to be actively promoting and supporting and making it possible for children to participate in exercise. And similarly for the school, in the face of uncertainty, schools and coaches, will restrict. So that leads to decrease in activity. The healthy routines don't develop. These sedentary habits get a little more established. And I think this medical stigmatization can be a really big part of it. I think you see, especially as kids kind of middle school, high school, as they start to be allowed to sit out more than what that kind of means for how much they, the kind of cycle continues, right? And they're different from their peers, and they're not able to do the things their peers can do. And this ultimately leads to all the kind of downstream effects that we know about in terms of obesity and comorbidities, and the cycle continues. So ultimately meaning that they don't really get all these benefits from exercise that are really well established. So in terms of our role, I think this can start really early, kind of at diagnosis, even fetal counseling, how we think about the messages and the frameworks that we're providing to families to think about how their child is going to live in the world. If we can be more promotional, be more specific and explicit about safe and effective exercise, and what that might look like as their child kind of goes through different developmental stages, I think can be really impactful and really gives the family the means to really support an active lifestyle for their children, and really, I think, hopefully yield the benefits of exercise. So kind of next step is this prescription. I am really curious to hear about our colleagues later throughout the week about the prescription piece, because I still feel like this is a challenge when I'm not able to actually, specifically be really actively involved in kind of the training, or where I just do the promotion. I feel like a little more comfortable in that area, but the prescription, I sometimes feel like it's hard to know, but I'm trying to kind of make some initial inroads to think about, all right, we have guidelines and we have, some thoughts around how we can actually be explicit about promoting exercise, just like any other medicine. But I think there's a lot more to kind of, for me to figure out from this perspective. But finally, it brings us to kind of this pediatric cardiac rehab and what we know about it in children with congenital heart disease. So we do have less evidence than adults, but I think the safety and benefits have been really pretty well established. And this is true across a range of diagnoses, simple, even complex, and even single ventricle patients, and across a wide range of benefits. Exercise capacity, we have some evidence for how ventricular remodeling and function actually gets impacted by exercise as a mechanism to improve exercise capacity. We know we can improve muscular strength. We know we can improve flexibility. And we know that psychological well-being and quality of life can improve with this intervention as well. And I always love this because I think a lot of money sometimes goes into medication trials or randomized trials looking at how a medication that has a bunch of side effects might have a very marginal improvement in exercise capacity. Shockingly, exercise improves exercise capacity better than any other medicine, really. So I think, people are sometimes like, wow, this is amazing. But it's like, well, yeah, like you got to practice the thing and then you'll get the result, right? And so I think if we could put even a fraction of some of the money that especially goes to adult trials to develop medications towards exercise training, I think that would be a really interesting and I think beneficial kind of place to put our money. So in terms of access and utilization in adult cardiac rehab, access is really limited, especially in rural areas, especially in minorities, especially in women, especially in patients with a lot of comorbidities. And utilization rates are dismally low at 24%, a range of 14 to 35%, depending on the subdiagnoses. And then in that 1/4 of patients who actually utilize cardiac rehab, only 1/4 of them actually get to it in a timely manner relative to their diagnosis. And only a little over 1/4 of them actually complete a full course. So one paper quantified this as 7 million missed opportunities, which I think sounds impressive. So I include that. But, I think when we compare that to pediatric cardiac rehab, where there's 10 or 15 maybe programs across the country that are really only just developing in the last 10, 15 years, the access is a huge issue. And I think hopefully something as a group of exercise cardiologists and people who find this to be important and think that this is really impactful can really start to move the needle on implementing exercise training and rehab interventions at heart centers across the country. The Boston group looked at even at their center, and we have one of the longest running, largest volume pediatric cardiac rehab programs. And even for them, their utilization rate, they estimated at 1%. So even in places that have it, we're probably underusing it. And very few places actually have it as an option for their patients. So I think obviously there's a whole world that we need to kind of open up here for these 1 million children with congenital heart disease. So again, bringing us back to the current model, we've got these 3 training elements: aerobic, resistance, flexibility. We've got these core competencies. But how does this apply to a kid who should be playing and should be active in a different way? So that's where I've been spending a bit of my time and thinking about, okay, so what are the goals? We want it to be safe. We want it to be effective. I think we've demonstrated there's a high degree of safety, both in adult congenital or adult cardiac rehab patients and in children with congenital heart disease. This remains something that, you know, we have to be thoughtful of in terms of how we risk stratify and think about how we support patients. But I think we've established that it is safe. Exercise is safe for kids with congenital heart disease. And I think we've established that it's effective in terms of improving stamina, improving exercise capacity. So for peak VO2, peak work rate, oxygen pulse, proxy for stroke volume, controversial proxy for stroke volume, and then your exercise capacity at the anaerobic threshold, we've been able to move the needle on. Multiple studies have shown this. And strength, I actually find, is one of the things that's most impactful for patients. That, like, if you start actually doing it, you can see the benefits so easily. Like, no kid cares about their oxygen capacity or their oxygen uptake. But to be able to actually do a pull up, like, or a push up, like, I think that is what I pretty much do these assessments to show the kids that they can do it, and that if they put the time in, the effort in, that they can do it. But it's also kind of fun to put it on a graph and show how much better they've gotten with the training program. Not many people care about flexibility, but I think it's an interesting kind of area that we don't really think about, and how even if you think about a kid who's had 3 to 5 sternotomies, how does that impact kind of their upper body and even flexibility of the upper body? We weren't actually assessing flexibility. We were just doing sit and reach tests. So we were just doing lower body flexibility, but actually looking at how much even our kids with congenital heart disease, who we didn't really think had any reason to have impaired flexibility, except that they maybe were less physically active, actually were much lower than kind of population norms in terms of their lower extremity sit and reach numbers, but that if they started practicing it, they could normalize just like other populations. But now we've started to actually integrate upper body flexibility assessments, because I am really curious about this. You know, how does having a sternotomy affect kind of your upper body musculature and flexibility? So TBD on that. And then I think this is a little bit of a question mark, but one of the big goals is, you know, we do this intervention and then does it last? And like, not all the time does it last, but there's some evidence that it can. So Rhodes from Boston looked at sustained effects, basically 9 or 7 months after a 3-month cardiac rehab intervention, and showed that those changes were sustained in that time period. So I think that's reassuring, but we also know that there's a drop off for a lot of kids if they're not actually in the program, in a structured program anymore, which I think comes back to goals and what are we really trying to do through these structured exercise training interventions. So I think that comes more to the psychology and the kind of habit formation that we're working on. And then improving outcomes, I think this is something we're still working on. The Cochrane review from 2012 kind of was like meh about it. You know, there's insufficient evidence to definitively determine the impact of physical activity interventions in congenital heart disease, and further trials are needed. So that's something that we all need to work on. But this all kind of comes to, what do we really want for our patients? And I really think of exercise as a way to help them thrive, and kind of more than their exercise capacity on an exercise test, more than the number of push-ups. What do we really want for them? And I think of this as fitness for life. We know that we can train a body, muscles, stamina. We know we can train that through structured exercise interventions. And similarly, we know that we can train mental skills. Just the same way as we think of a bicep and having an intervention that actually specifically addresses how your bicep muscle can grow. I think the same thing goes with mental skills and habit formation. So I think of those just very similarly. And I think that's actually, that two-pronged approach is actually essential to thinking about how we have sustained behavior change. So we're going to take a little bit of a this is how I came to really value a lot of these is a few different kind of influences. So before I went to med school, I worked at UCSF. That was basically the Center for Health and Community, had kind of a stress response lab, and I worked on a research study there with Alyssa Apple. And she had some really interesting stuff about chronic stress, acute stress. And so I've been really into that and thinking about how this applies to our patients. Stanford also has a mind and body lab where Carol Dweck is the kind of growth mindset person, and she started this lab, and they're continuing to do really interesting work, and that's been really impactful to me as well. And then recently become really interested in this trauma-informed sport or trauma-informed approach to sport and how this is actually really important. So we'll get into that as well. And all this kind of coalesced as I was arriving to Boston and seeing how this exercise intervention was really changing something about the kid, like not just about how they could exercise, but like this transformation that we saw, not everybody, but in some kids is like magic. Like, it's like, if you can get that, you can see that light switch turn on. I think that's what I felt like. I was like, what is that? What's going on there? You know, what are these things these mental skills that we're maybe not even explicitly training, but we are through exercise. How do we make that more concrete and more specific and actually, develop that into something that can be trained? So for Alyssa Apple, this is the acute versus chronic stress kind of concept. We know that chronic stress is maladaptive and damaging. And that adaptive responses to stress, especially if our body can process them as acute stressors, is actually physiologic and might be beneficial. And that adaptive stress responses can be learned, and that we can teach those stress responses and help combat the effect of chronic stressors. And I love this because I think it applies so much to our kids with congenital heart disease. So how do you handle stress like a lion, not a gazelle? How do you change how you think about your stressors so that you're not the victim, but that you're the hero of your own story, which is kind of the narrative that we're trying to shift in our patients. And then Carol Dweck's growth mindset and the Stanford Mind and Body Lab has also been really impactful to me. We have a kind of starting in Boston. We've developed a partnership with them. They're really interested in exercise mindsets and illness mindsets. And I think all of that's super interesting when we think about how we develop, even how we develop a heart center, or how we develop a clinic, like all the ways that we actually kind of frame the narrative for our patients is actually incredibly impactful. But especially when we think about training, I really think growth mindset is one of the most important things that we can kind of help teach kids, that just because they are a certain way they are now, that's not something that can never change. And so this is where the growth mindset versus fixed mindset and teaching people how to think about, yeah, I can't do that, but that's just because I can't do it yet. How to kind of shift that needle, I think is, move the needle on that, I think is one of the important things that we can do through exercise. And then I think I recommend everybody read. I think this was really impactful to me in thinking about trauma and how adverse childhood events or childhood experiences, as how those ACEs are actually really impactful in terms of how children move through life for the rest of their life, but also how even these ACEs are things that are like, the death of a parent, an incarcerated parent, or like abuse or neglect in the home. That doesn't account for community trauma, discrimination. It doesn't account for medical trauma. Like, these ACEs are actually not defined in a way that directly apply to all our patients, but they apply to a big proportion of them. Like maybe half of them probably have ACEs by the data that we've looked at, but probably every one of them has some kind of medical trauma that I think is actually really important. So this really looks at how do we think about surviving to thriving, and how exercise training is actually uniquely suited to be a possible solution for a lot of these patients. They go through kind of how physical activity is good for all aspects of your brain and body, how relationships, especially consistent and caring relationships, can really, really important, and the kind that you can grow in a team setting. How structure and consistency and predictability in your environment can actually be really impactful, and how exercise training and the routines that you implement through exercise training can actually be impactful. And then I'm really interested in the confidence building. How do you change that I can't do this to I can do this? So all of this kind of came together when I was in Boston and seeing this kind of magic happen with patients and just realizing that actually these are really concrete things that if we can dissect out these pieces and try to teach this to kids and integrate this into our exercise training interventions, you know, maybe that can actually be really impactful. So fitness for life, we've talked about a few words like kind of the anti-frailty. I think of thriving, resilience, people who have self-determination, healthy, strong, independent, well-supported, being confident and capable. Like I'm still figuring out what this fitness for life looks like and how through an exercise training intervention we can actually grow this. But I think it has something to do with all of these things. And so it's still kind of in the works of putting it all together and figuring out, you know, what the secret sauce is. So current model, pediatric cardiac rehab, we've talked about. But there's missing pieces. So we know that aerobic strength and flexibility and the add in balance there are kind of important pieces of exercise training. And then there's probably a lot of other missing pieces, like how do we think about the parent and the family structure in this? How do we think about fun and play in this? But the two that I'm really working on, kind of diving deep with, they're mental skills and super skills. And super skills I think of as motor proficiencies. So I'm going to take a break. This is like a whole minute, so just bear with us, but it's like such a good, it's from Sandlot and it's such a good flip. So, oops. Such a good clip, we have to. We worked on the last ones, maybe.
You can hack it out.
That was good.
I think that you're gonna have to do some
Back to
interpretive
that.
dance.
All right, well, you can watch, but basically it's this kid who comes to his new neighborhood and he's like never done exercise, physical activity before. And so the whole crew in his neighborhood is like obsessed with baseball, right? And so he's like, all right, I'm gonna go out and play baseball. And he has never thrown a ball before. He doesn't even know how to catch a ball, right? So this ball comes, he's like terrified. He really doesn't want it to actually have to do anything. So it goes out to like the, you know, the outfield, but it does come and he's like, oh no, right? I don't know how to do this. But you know, he gets over that. He's like, don't be a doofus. Don't be a doofus. He's walking to pick up the ball. And then he's like, okay. I don't know how to throw a ball, right? And so he's like, oh gosh, like, does my foot go here? Does this, like, does my arm go here? Like, how does this actually work? And everyone's like, oh my gosh, just throw the ball. Like, it's just, it's like the most cringe word. Like, I just like want to like shrivel up for him, right? And so finally he throws it, and like, can't even throw it, right? So I actually think about this a lot. It's kind of supposed to be like you know, this poor kid Smalls, like, how do you actually think about that is actually a skill that needs to develop, and that if you don't develop that, actually you're creating a huge barrier to actually feeling confident to go out and put yourself out there and developing the confidence to actually have these moments of failure actually need to come from some foundation of having had a prior experience with it. And so I think that's where this motor proficiency actually comes in. So we think about neurocognitive outcomes and how a lot of this, you know, the last 10 years, a lot of our field has really thought a lot about how the kind of hits from an early time in life and throughout childhood and fetal life contribute to lower intellectual abilities, impaired executive function, attention and behavior difficulties. And we're really putting a lot of resources in developing cardiac neurodevelopmental programs. But we haven't really done that with the motor impairments quite as much. This review in pediatrics from a few years ago was looking at motor impairments in kids with CHD, and looked at 46 studies looking at gross and fine motor skills in kids 0 to 18 years old. And they found that severe motor impairments, you know, range from basically 0 to 6. Like a ton of people potentially have severe motor impairments, but we're not actually quantifying it very well. And I thought what was most striking is that 40 of the 46 were in kids under 6 years old. There were only 5 studies looking at motor impairments in kids 6 to 12 years old. But in those studies, there was actually a pretty high prevalence of severe motor impairments. And there was only one study looking at adolescent age 13 to 18 years old. And in that study, 42% of adolescents had mild to severe motor impairments, which with up to a fifth of them having severe impairments. And, I think we do, I don't know about you guys, but in my experience in the institutions I worked at, I do a pretty good job of, as an inpatient, when a kid's in the hospital, referring to PTOT. They get discharged, and it's really hard to keep that up. And I think a lot of people kind of fall through the cracks. And when we're seeing them as part of our exercise training intervention, we're seeing them often when they're over 8 years old or high school age. And it's striking how many of those kids don't know how to run and breathe at the same time. It's actually, there's a lot of motor impairments that really contribute to, I think, participation in regular activities that actually are really foundational to developing exercise habits throughout life. So how do we grow it? We need to measure it first. We can use exercise training interventions as an opportunity to identify therapy needs, but we can also probably integrate these motor skill training into our fitness training programming. So there's a really great physical and occupational therapy group in Dallas who's really interested in partnering with our exercise intervention, our cardiac fitness program, to really develop this out, start assessing it more comprehensively and thinking about how we can tie it into our training better. And so the second missing piece is the mental skills piece. This scientific statement was looking at psychological outcomes for kids with congenital heart disease, and really looking at how, kind of throughout the lifespan, there's multiple hits that can kind of contribute to an increased prevalence of mental health disorders. And it's hard to kind of evaluate, I don't think of mental skills as being the same thing, or lack of mental skills as being the same thing as mental, as psychiatric diagnoses and disorders. There's just not a lot of data on deficiency of mental skill development. There is accumulating information about anxiety diagnoses and depression diagnoses, both in kids with congenital heart disease and adults. And so I think that there's that story is in there about how a lot of anxiety and depression maybe does relate to a lot of the lack of mental skills that might have been not developed throughout childhood. And so when I think about how do we grow these, same thing, we have to measure it. We can screen for it, we can teach it, and we can integrate it into life. So we're looking at exercise training as an opportunity to identify these needs, but also thinking about how mental skills training can really tie into our exercise training. So I partnered with Lonnie Silverside, she's a performance coach, to develop a curriculum where we're really looking at 8 mental skills and trying to tie that into our exercise training across an 8-week program. So we picked 8. We started with mindfulness. You kind of need this as a foundation of self-awareness and insight into your own thoughts as a kind of the foundation to build additional mental skills. The growth mindset I mentioned, the belief that you can get better at something with time and effort, and the process is more important than the outcome, which I think pertains to kind of individualized fitness. And actually, gratitude's been shown to be really impactful to quality of life. Growing an ability to see the good in things is key to resilience and overall well-being. And all of this contributes to well-being, something that I think, or to resilience, something that I think a lot of us are really interested in when we think about our kids and the obstacles that they're going to face as they go through life, and how they persevere and kind of bounce back from those setbacks. I think is one of the most important things that we can really help them with. Self-confidence is part of that story. I think believing in yourself comes from having prior experiences that you learned from, and how we support our patients might be that we can help them build that library of positive experiences that they can draw from later. And I think all of us can benefit from stress management tools and learning how to integrate these techniques into our daily lives. And finally, all of these and then the teamwork piece is kind of our 7th, and that's where we really think about how do you communicate your needs, how do you rely on your team, and how do you rely on your support system to get through hard times. And then all of these kind of mental skills contribute to the bigger goal of helping our patients develop positive behaviors that really are sustainable and become a new way of life. And learning how to set goals and create habits to work towards these goals is really important to translating mental skills into concrete action, I think. So as an example, for mindfulness, there's actually quite a bit of data around mindfulness and how that actually pertains and connects to health outcomes. So we thought this is one of the important parts. There's a nice kind of review that looks at the physiologic mechanisms through which mindfulness can actually impact health outcomes. And so, it's not rocket science. We just do a very small thing, but we're as our first draft of this mental skills curriculum that we've only been doing for 6 weeks or so. We have kind of 10 minutes in the beginning where we really focus on what is the skill, we practice a little activity where you try to implement the skill, and then we integrate that activity into basically a motor proficiency-based game that's actually integrates some aerobic work, some strength work, but really trying to bring in. So for mindfulness, we do mindful breathing at the beginning and teach a skill that we teach them how to implement that in kind of a daily life way. And then we have 10 minutes in the middle of the session where we do something that's mindfulness based. So for example, it'll be like learning how to juggle, where you're really focusing on the balls, or balancing on a balance ball and like just passing a ball back and forth. And the mental skill is the mindfulness, the motor skill is the hand-eye coordination, and then we tie that in together. And so our super skill theme is the eye on the ball for the week. And so this is one way that we're trying to do this, and we've done this with 8 different mental skills. So I really think that these mental skills, I don't know if these are the ones, but I think some curriculum to think about how we train mental skills just the same way as we do a muscle, I think is one of the pieces to really thinking about how we help our kids thrive and develop fitness for life. So for our program, like I said, we just started in April with kind of our soft trial or our soft launch group of 4, and we have another 4 starting this week. We basically do kind of the exercise cardiology intake visit where we do cardiac risk stratification and identify the medical kind of components that might inform their exercise prescription and plan. And then we have these 5 domains: the mental skills, aerobic, strength, flexibility, and balance, and super skills. And we train throughout the program along these 5 domains. And the training sessions are with an exercise physiologist. We do it in person because I think we need to learn how to deliver the program first, and then hoping to have a virtual offering the way that you guys have soon. And then every patient's kind of on their own journey, but based on their risk stratification, we have an exercise prescription, and they advance throughout 3 months of the program. We have assessments that we do at baseline at the end, and then we also have monthly assessments that we do throughout the program. And then at the end, I see them, we talk about how it all is going. It's theoretical because I haven't actually done this part yet, but we talk about how it's going and what they learned. And really what I'm hoping that they get out of it is, yeah, like the PPO2, the push-ups, all that, whatever. But what I'm really hoping is that they develop these positive mental skills and a positive exercise mindset that helps them actually frame exercise for the rest of their life. And I think we talked a little bit about kind of symptoms of exercise and learning how that's actually, what a physiologic normal response to exercise is versus something that's indicating that your heart's in trouble. So really understanding what those symptoms look like and reducing exercise-related anxiety, I think, is actually a huge thing for our kids. And ultimately empower a self-directed kind of habitual exercise habit is one of the goals. But I think globally, I think about rewriting the narrative so that, kids think about themselves not as the victim of their story, but actually the hero of their story, and empowered to actually have some self-determination. So that's our program, and really, we've been developing the curriculum, but really the big part of what I've been doing is building a team. So we have a really great kind of team. Think about the core team of trainers, and then we have kind of leadership that helps us, figure out where to go. And then we have this advisory board that really is a large group of people that are really impactful to kind of help us identify resources that we need for our patients and link them to those resources. So that's been our model. I'm sure it will be a work in progress and continue to develop over time. So ultimately, summary is that exercise training is safe, effective, and I think essential to pediatric congenital heart disease patient care. We know that improved exercise capacity improves outcomes in at least adult populations, and that exercise training increases exercise capacity better than meds. Exercise training also provides an ideal opportunity and format to grow other competencies that I think are important for fitness for life. And that really this kind of adult cardiac rehab model, I think, explaining that to kids gives us a interesting opportunity to really innovate and improve the model. And like I said, our project is kind of a team project and a work in progress. And I'm really grateful for people like Jesse to kind of help me think about how to navigate the issues that come up, but would love to hear feedback from anybody or thoughts from anybody about it. So thank you, everybody. Appreciate it.